So this will always be a point in our mind when we consider ARNI as compared to when we are starting. What are the contraindications? So contraindications or adverse effects are few and far, as we have shown. The most important one is hypotension, which we should be careful of. Others are like for ACEI, because valsartan is there, and we know that hyperkalemia is one of the risk factors which can be there. Impaired renal function in only around 3% of the patients, cough in around 9% of patients, and angioedema in only 0.5%, and not significantly more than enalapril also. So only one side effect, hypotension, minimally more than enalapril, and which can be taken care. We have discussed a slide that how we can manage patients who have hypotension and slowly up titrate them or reduce their diuretics, and volume depletion can sometimes help in these patients. So hyperkalemia is definitely not a very troublesome thing, and even as compared to ACE or ARBs, it is still less seen in patients who are given ARNI as compared to ACE inhibitors. The contraindications are very few and far, and we should know them. That we have discussed that patient who is already taking a ACE inhibitor or ACE inhibitor, sorry, and within 36 hours of use of ACE inhibitor, we should not give ARNI molecule. We should give a cool off period of 36 hours, and then only we should start ARNI in those patients who are already on ACE inhibitors. Any patient who has a history of angioedema with or without ACE or ARB, in pregnant females who are lactating, severe hepatic impairment is one thing we should keep in mind. If the patient is severely having deranged liver enzymes or severe hepatic impairment with child-pug C classification, then we should avoid use of ARNI. And concomitant use of a renin inhibitor, we know aliskiren sometimes is used in diabetic, not commonly used in India though, but if it is in use, then we should avoid ARNI. Or known hypersensitivities, definitely, because ARB valsartan is one of the components of ARNI. So if it is a known hypersensitivity, you should avoid. Caution is only renal impairment only if it is severe, in even up to a GFR of more than 30, it is not a problem. But if it is less than 30, then the starting dose should be reduced to 50 milligram twice daily, and we should go up very gradually, maybe every 4 weeks, and we should keep a very keen eye on the potassium levels. Again, hepatic impairment, child-pug A and B, A, there is no dose requirement, dose adjustment needed. In moderate hepatic impairment, you can again reduce the starting dose to 50 milligram twice daily and then go forward. Renal artery stenosis is something you should be cautious of when using ARNI. Patients who are having systolic blood pressure of less than 100, be very cautious, go slow on them. Patients who are volume depleted, they can have precipitous fall in blood pressure with the use of ARNI. So always have an idea of the volume status of the patient before adding this molecule. So drug interactions, we have discussed that ACE inhibitors, aliskiren, potassium sparing diuretics can lead to increase in potassium levels. NSAIDs use concomitantly can lead to risk of renal impairments. Lithium toxicity chances can increase, and birth control pills, they can also containing drospirenone, and it is one of the things which can have interactions with the ARNI molecule.